So today we get to talk about chapter 16, which is on endocrine system disorders. Now, the endocrine system is a very important system in our body because it encompasses so many different things. It has the pituitary gland, the thyroid, the ovary, pancreas, testes, thymus. So a lot of the different organ systems that actually keep us functioning with basically hormonal control, but they're very important things, okay? Trying to get my desk all set up. Hold on. Okay, so some of those major endocrine glands that we're going to be talking about are going to be, again, the hypothalamus, the pituitary, the pineal gland, thyroid, parathyroid glands, thymus, adrenal glands, pancreas, ovaries, and testes. So this is where the different endocrine glands are going to be located in the body. And this is figure 16.1 in your book. And this is just showing you that, for instance, your pituitary, your pineal, those are in your brain region, your thyroid is in your throat region, your ovaries are in your abdominal region, testes, etc., dependent on if you're female or male. And yes, this is the ovary, not that. Sorry, my pointer was off. And the pancreas and adrenal glands are going to be in the midsections. So talking about the endocrine system, well, basically the hormones are going to be acting as chemical messengers. And so what they do is they release this chemical signal, and then that's going to go to a targeted receptor. The receptor is only going to be able to bind to that specific neurotransmitter or chemical transmitter, not neuro necessarily. And so they're very targeted and very specific. We also are going to be talking about negative feedback systems, and so these are very common, and so we'll talk about this, but some common negative feedback examples are going to be regulating blood glucose levels, insulin increases or decreases, therefore signaling, how we can move glucose into the body or out of the blood and into storage, etc. And then also the chemical structures that are involved in the endocrine system, including the peptides and steroids. So as an overall grouping, we're going to want to be able to classify the different things happening by the source that's happening, on where it's coming. And so there's a little bit of a summary table on 16.1, but the list for these is going to be on page 401. And so I want you to be able to determine what is coming from the hypothalamus, what's coming from the pituitary, what's coming from the thymus, the thyroid, pineal gland, etc. So we're going to break each of these down. So in order to start, we need to figure out how to classify based on chemical structure. So basically, we have a couple different, I'm trying to move me out of the way. A couple different chemical structures that we need to talk about. And one would be that we have steroids, and these, I'm going to pause for a second, hold on. Okay, we're back. I had to move my screen around so that I wasn't covering all the slides. All right, so we're going to be classifying these by chemical structures. And the two main ones are going to be either steroidal or non-steroidal. And so if they belong in the steroid classification, then these are going to be those lipids, and these are going to be able to enter the cell nucleus in order to initiate or start the transcription directly. Where if it's non-steroidal, then this is going to need a secondary messenger system to help activate the transcription in the nucleus. So transcription is again going from DNA to RNA, and then translation is RNA to the actual protein. Here's that nice little summary table of the sources of the hormones and their primary effects. And again, this is table 16.1. And so this is just going to say, that they're hypothalamic releasing hormones, hypothalamic inhibiting hormones, growth hormones, etc., all the way down to epinephrine. And then the source is either going to be hypothalamus, pituitary, the adenoids, all the way down to the adrenal medulla, and then also some primary effects. So this would be a great thing to put on flashcards so that if you are a flashcard type person, that you can study those that way. Okay. So how do we control the endocrine system? Well, the endocrine and nervous systems are going to regulate metabolic activities. And so we kind of pinpointed a little bit on negative feedback systems, but we have to talk a little bit more about it. And so the negative feedback system is going to be basically like how your body reacts off what's there in order to make adjustments to keep things at the homeostatic or at the correct level. We also do have some positive feedback, but that's more of it's not as common. Negative feedback systems are the most common. But where we would have a positive feedback would be in blood clotting or in childbirths. But the majority of things in the body do run off of negative feedback systems, but do know that there are a couple exceptions and there are some examples of positive feedback. And some hormones can act as antagonists, and these can be like calcitonin and your parathyroid hormone, as well as insulin and glucagon. And so antagonist means they work against each other, right? So insulin and glucagon, these are great examples, right? Insulin tells your body, hey, look, we have too much sugar in the blood, pull some out and into storage. Where glucagon literally saying, the glucose is gone, the glucose is gone, right? So these are acting inversely of each other or antagonistically. Okay, so that's just kind of a good way that you can remember those. So how are hormones released? Well, again, we said that most of them are going to be controlled by that negative feedback mechanism. And this is where the endocrine and nervous systems are going to work together to regulate those metabolic activities. And this can be a very complex system for some hormones. And the secretion can be controlled by more than just one mechanisms, right? And so this is where like drawing flow charts and diagramming can really help to understand and learn what's going on. We also have the rate and timing of the secretion that can vary. And so this would be like a cyclical pattern. For instance, in females, the hormonal cycle can control the menstrual cycle, right? So estrogen peaks, estrogen drops, same thing, etc. So things are not static. They do have, most of the time, they can have a cyclical pattern. So here is an example of what negative feedback would be. And this is figure 16.2 in your book. And so this is the negative feedback mechanism with glucose and insulin as well as glucagon. So just the little key, which is down here, glucose is going to be the yellow box, insulin is the blue circle, and then glucagon is going to be the red triangle. So up here we have an example of high blood glucose. So you can see we have our little yellow squares that are going to be traveling in the blood. Well then, our beta cells in the pancreas are going to say, hey, we have too much sugar in the blood, so why don't we get some of it out of it? So it is going to release insulin. Well, then insulin is going to, down here, promote the transport of glucose into the cells, and that is using GLUT4 transporters. That's just some extra information if you ever wanted to know. Well, then what happens if we have low blood glucose? Well, our body's like, oh, all right, and our alpha cells here in our pancreas are going to notice that we have lower blood sugar levels, and it's going to start secreting glucagon. And remember, glucagon is the glucose is gone, the glucose is gone. And then what will happen is it will stimulate the liver to make new sugar, or actually also it can break our glycogen stores in glycogenolysis. So that would be an example of the negative feedback. Talking about endocrine disorders, well, all disorders reflect impaired control or feedback, and this can result from excess hormonal levels. And so some examples of what can cause that could be that a tumor can produce very high levels of a hormone that we weren't ready for, or I have a case of the yawns, I'm so sorry. Or the excretion can occur by liver or kidney, and that can be impaired. So no longer are we releasing the amount of hormones that's supposed to be out there. We can also have a congenital condition that can produce excess hormones. So you can see that a lot of disorders, the disorders are going to be affected by either the lack of or the overproduction of hormones due to the impaired control or the feedback mechanism being broken. So when we're talking about a deficient amount of hormones or the reduced effects, what we're going to see is that maybe a tumor is going to cause us to produce less than what we're supposed to. So this would result in us having too little hormone. We can also have inadequate receptors. So we can be flooding the system with the hormone, but we don't have the receptor to actually attach onto that signal, so it's not doing us any good. We can also have that antagonistic hormone, like we just said, with insulin and glucagon, And then this, like the glucagon hormone could be overproduced, and it's saying, hey, we don't have any sugar, we don't have any sugar, we don't have any sugar, therefore releasing a lot of sugar into the blood, right? So it can just kind of be broken. Malnutrition, so if we're not getting enough nutrients and our body's not regulated, then that can be a huge problem. You can also have atrophy or the breakdown of that tissue, or the surgical removal of the gland, right? And so, for instance, my mom had thyroid cancer, and so she had to have her thyroid removed, and so she no longer can produce the hormones that are secreted by the thyroid, right? Or it can also be a congenital defect, which can cause, again, just a lack of the hormone being produced because you don't have the genes to, say, produce it. So how would we diagnose this? Well, we can use blood, urine, scanning, simulation, biopsies, right? So when we're looking at blood tests, what we're really going to be looking for is to be able to check those serum hormone levels, right? So that we can see just what our baseline is. And then if it's above the normal base, then we know that we're overproducing. If it's under, then we know that we're underproducing. You could also do a radio immunoassay. And so this is kind of like when they do, they can do thyroid with this, right, where they put a radioactive tracker in there, and then they trace it through your whole body to see where things go, where it's blocked, etc. Then you can also have immunochemical methods, which would be like doing an ELISA or some other type of a laboratory test off of your blood to see if you actually have the hormones present. Urine tests, so this would be good, for instance, for diabetics, because they can detect ketones in the blood, or in the urine, by peeing on a stick. Or pregnancy tests, right? You're looking for the HCG hormone, if I remember correctly, right? And you're peeing on a stick to be able to test that. You can also do stimulation or suppression tests. For instance, if you are pregnant, they sometimes have you do glucose tolerance tests. So you're going to give yourself more glucose than what you're normally eating, right? And then you have to see how your body is going to react with that. You can also do the scanning, which is ultrasound, magnetic resonance imaging, like MRIs, etc. And so you can actually see, like, oh, is this organ even there? Are we, having a problem, etc. Or biopsy. So like with my mom's thyroid cancer, they did a biopsy, saw that it was cancerous, and then they went ahead and removed it. So there's also different types of treatment that we can do. And so basically, if we have a deficit, we can treat it with a replacement therapy. And so in an instance with that is like, if you can't make insulin in your body because you're that type of a diabetic, well, then you can actually you could give a shot of insulin so that you can supplement it, right? Or I had a friend of mine growing up, and they were really short. They had stunted growth. So then they gave them a shot of human growth hormone, and they were able to supplement it, right? And then he was able to grow to a normal size. If you have too much secretion, this sometimes can be treated with either medications to reduce it, surgery to remove it, or radiation to kind of kill that area that's acting up. So talking specifically about insulin and diabetes mellitus, which this is very common in the United States. So this starts on page 404 of your book, and it is really important to understand the two different types and what's going on. So diabetes mellitus is basic problem is that you have inadequate insulin, okay? And so those insulin, they aren't going to be able to have the desired effect in the receptor tissue. And this is because you are deficient in secreting insulin. And so what we have to do, or what happens, is that you produce insulin antigens, right? And so that can lead obviously to diabetes. Diabetes can result in or from an abnormal carbohydrate, protein, or fat metabolism. So basically, diabetics, since they might not have the correct signals, like to get the GLUT4 to the cell membranes to actually bring the sugar in, well, then they can process those carbs, which are sugars, very different, right? Or they process our protein, you can process your fat. So my father-in-law happens to be diabetic, and actually diabetes runs in my family. And you should be very careful about what you eat, because you have to keep your sugar control or intake under a certain level. Some tissues can transport sugar in the absence of insulin, and those examples would be like the central nervous system, the kidney, the myocardium around the heart, the gut, and the skeletal muscle. And what's interesting is skeletal muscle can partially meet tissue needs without insulin. So that's kind of cool. It's kind of like a little bit of a backup system. So specifically talking about the types of insulin or of diabetes, and there's a summary table on table 16.2, again on page 404. But type 1 is going to be the autoimmune destruction of the beta cells in the pancreas. So we already talked about what those beta cells were and why they're important, okay? So if we don't have them, well, then that's going to cause a problem. Well, then this is when the insulin replacement is going to be required because your body can't make enough insulin, so you need to supplement it. This can have an acute onset or a rapid onset in children and adolescents. And this is the one that's not linked to obesity. And genetic factors can very well play a role. So, diabetes can run in the family. So I know I have to be careful because it runs on my dad's side of the family. So I really have to keep that in mind as I'm aging. You have metabolic changes, and this would be from a catabolism of fats and proteins. And remember, catabolic reactions are ones that break things down. So I always say that I have a cat named Sophie, and she likes to break things. So catabolic are those breaking down reactions. So if we basically can't break down fats and proteins, well, then we would end up having a lot more around than what we should. So we'd have excessive amounts of fatty acids and those metabolites because we can't break them down. And this can cause the production of ketones in the blood. Okay, and so this is why you can pee on that stick and you can check for your ketone levels. And this can go on to cause ketonuria. And this is where we would have decreased levels of serum bicarbonate, increase in pH of the body fluids, or keto acids that are going to be excreted in the urine. So again, this is like, diagnostically, you can check for those ketones in your urine. So ketones in your urine, right? And just see what's going on. And this can also cause a decompensated metabolic acidosis to occur. And that's when you get very, very in dangerous territory. Okay. Type 2 is non-insulin dependent. And this is where oral hypoglycemic medications may be used. And this can be caused by a decrease in the production of that insulin, which is the hormone that pulls the sugar out of the blood and into storage, or by an increased resistance to the body cells to the insulin that you are producing. The onset is usually slow and insidious, and this usually happens in older people, older than 50. The last few years, some of these demographics have changed as the American diet continues to change, and just a lot of things are going on. But in general rule, 50 years-ish is when you start to develop it. And this is usually associated with obesity. And this is a component of a metabolic syndrome. And again, this is increasing in incidence in teens and young adults. And a lot of it is from, unfortunately, the American diet, lack of exercise, and just some of the foods that we are ingesting. We can talk about it if you want to in class, but there's a lot of people that think GMO foods are horrible. Some don't care, whatever, but our foods are different than what we were eating even 50 years ago. And so my personal opinion is that could have some potential effects on it, but time shall tell. Type 2 can be controlled by adjusting what you eat and also increase the body's use of glucose. And how the number one way that you can do this is by exercising. Okay, so they say diet and exercise, and that's very true. And this can lead to reducing insulin resistance. And also a good side effect is that it's going to help stimulate those beta cells in the pancreas, therefore to produce more insulin. We have to monitor your blood glucose levels as ordered. And so that's with the finger prick or with, of course I'm forgetting, like the monitoring things that you can, put into your body, and they monitor constantly for 2 weeks or whatever. And so those are very good and important. And then if you are insulin dependent, then you have to know how to properly administer insulin to maintain those levels of glucose in the normal range. Because if you dose wrong, you can cause death, right? So you need to be able to not overdose insulin or not underdose it, because it can be pretty dangerous. And then you also have to have routine follow-ups and blood testing. So with the initial stages of diabetes, okay, so this is getting into the pathophysiology of it, and this is now on page 405. So the initial stage is going to be insulin deficit, and this results in a decreased transportation and use of glucose in many of the cells. The blood glucose levels will rise, and this is called hyperglycemia. So high is hyper, glycemia is sugar. So you have high sugar. And then you can also have excess glucose that's found in the urine. So a lot of times, if you have a diabetic, you can smell it on either their breath or you can smell it in the urine, right? Because you're going to be having extra sugar be in the urine, and therefore you'll be able to smell it. You tend to urinate more frequently, okay? And then because you're urinating more frequently, you can have fluid loss, okay? And therefore this is going to result in dehydration. And then the dehydration causes thirst, so that causes this kind of vicious cycle, right? So this is also like in pets, they look for excessive thirst or excessive urination and things like that. So your general manifestations are going to be that your insulin deficits are going to result in decreased transport and the use of glucose in many of the cells. And so this can cause prophagia and also fatigue. And the blood glucose levels can increase, okay? And so that would be the hyperglycemia, or it can cause excess glucose in the urine, which is glucosuria. So glucose is sugar, urea is urine. So high glucose in the urine, glucosuria. And then the dehydration is going to result, again, from those hyper more active, osmotic, so hyperosmolar filtrate. So you're filtering more, therefore you're getting more output. And then this would be polyuria with excessive urine, polydipsia is excessive thirst. So how can we diagnose this with diagnostic tests? Well, you're going to be doing a fasting blood glucose level. And so they say, like, we have a blood glucose monitor here at home just to, keep tabs on things and stuff. And so they say that you should take your sugar right before you eat or as you get up, right? As you get up would be your resting glucose levels. But, your insulin's going to be working pretty quickly. And so if you eat something and then you take those, measurements 10 minutes later, it'll already really affect what's going on in your sugar. And so you want to be taking your fasting glucose levels, and then you can do glucose tolerance tests. We talked about those kind of in pregnancy. And then you can also have glycosylated hemoglobin tests. And this is where you would have either clinical or subclinical diabetes, and you're just going to be monitoring the glucose levels over several months to see if you have to go on and treat it. So your treatment principles, okay? So this would be where you're going to be trying to maintain the blood glucose levels within that normal range, okay? Because again, if it's outside of that normal range, then we can cause a lot of problems, right? And so by maintaining it and monitoring it, it's going to be helping to reduce any complications that may occur. Also through diet and exercise, okay? So again, exercise is going to reduce the blood glucose levels because the skeletal muscles that are storing those glucose as the form of glycogen is going to end up using it to contract, okay? And so that will overall reduce your overall sugar levels. You can also use oral medication, and this would be, causing you to either stimulate or increase your insulin secretion or reducing the amount of blood glucose to therefore reduce the amount of blood glucose level. Or you can also do insulin replacement therapies. Okay, so if obviously you're not producing it, then you're going to need to take a shot in order to, make sure that your sugar stays at that level that it needs to do. So, of course, with everything, there are complications that can occur. And so complications are going to be directly related to the duration and the extent of what's going on, right? And so many factors can lead to the fluctuations or changes in the serum glucose levels. So again, you can have variations in the diet as well as your alcohol use. You can have a change in your physical activity. There can be an infection that can cause disruptions or vomiting. Okay, vomiting causes dehydration. Dehydration causes a whole bunch of physiological problems. And these complications can either be acute or chronic. And so the acute ones are being started to be talked about on page 407. So some of your acute complications can be hypoglycemia. And so this is kind of also called, not kind of, it is also called insulin shock. And this is most common with insulin replacement treatment. And this can occur because you took too many drugs, right? And so this is why you really need to monitor your dose, check your blood sugar before you give a shot, etc. So, I mean, I know that experienced diabetic people, they can say, oh, I knew my blood glucose was blah, blah, blah. But I had a friend, and her sugars were off the chart, and she would be like, oh yeah, I just kind of dosed myself this. And I'm like, you need to check your blood levels before you do that. She disagreed with me, but we are no longer friends, so I can't follow up on her, but last I knew she was still alive. This can cause excess insulin that is going to be in our circulation. And so because we have more insulin tells your body to pull sugar out of the blood and into storage. So because of that, if we pull too much out, then it causes a glucose deficit in that blood. This can again be life-threatening because, first of all, your brain needs sugar, your body needs sugar, but specifically your brain. And so this can cause brain damage if it is not treated. And this can often follow strenuous exercise, and I'm talking strenuous, right? And with diabetic complications. And then either a dosage error in your insulin, it can cause vomiting, and this can also occur from skipping a meal after taking your insulin. So you really need to make sure to pay attention to not go into hypoglycemic shock. And so this is figure 16.3, and so this is hypoglycemic or insulin shock. So right here in 1, it says that there is excess insulin in the blood, and then the increased transport of glucose into the cells occurs, and then this hypoglycemia or low sugar is going to cause the decreased central nervous system function. And so clinical signs of this could be weakness, confusion, that pallor, diaphoresis, tremors, or tachycardia, right? High heart rate. And because this causes a stimulation to the sympathetic nervous system, or SNS. So both of those can go to create each of these symptoms. And then what happens is you have increased gluconeogenesis in step 5 here. And then for step 6, this excess insulin can then transport glucose into the cells. Then that branches off, and you can have your glucose intake, therefore returning back to the normal physiologic state. Or you can have a complication where you would have no glucose intake, then the blood glucose levels decrease even further. The neurons can't function without that sugar, and therefore it can put you into a coma and or death. So up here in this picture, and again, this is going to be figure 16.3, the I is going to be insulin and the G is going to be glucose. So you can see how they bind together and how they move and get brought into the cell, etc. So what are some of these signs and symptoms? Well, we just talked about it in that summary figure, but it's going to be the signs and symptoms of hypo or low sugar is going to be where you can have disorientation and a change in your behavior. You may appear to be impaired. You can have anxiety or decreased responsiveness. You can have decreased blood glucose levels because we took too much sugar out of the blood and into storage, right? Therefore causing the low sugar. You can have decreased blood pressure or an increased heart rate. And this can decrease the level of consciousness. So with this, to help get people out, you need to immediately administer glucose to prevent brain damage, because our brain functions off of sugar, right? So we need to immediately get that sugar back up so that we can take care of it. And so this, again, is going to be the hypoglycemic shock that we just talked about, and all of those signs and symptoms again. So the emergency treatment, this is just good knowledge, even if you're not going to go on and treat patients. This is just good knowledge if you know that one of your friends tends to have low blood sugar. So if they are conscious, immediately give them something very sweet. So fruit juice, candy, honey, sugar, anything that can immediately cross into the blood and get absorbed and go. But if they're unconscious, don't give them anything by mouth because they can actually choke, right? So this is going to cause IV supplementation of glucose, and a 50% solution is required. And so also note that diabetic ketoacidosis, which is also can be caused by diabetic coma or hyperglycemia, can also cause the loss of consciousness. So the emergency treatment is going to be insulin fluid, sodium bicarb, and the assessment should be done to differentiate the cause. And so it's a little bit different if we have hyper versus hypo. So, but if you know that your friend tends to be very low in sugar, you might want to keep sugars on hand, right? So what about DKA? This is one of the most commonly talked about not diseases, but conditions that can arise from having insulin problems. And so DKA is diabetic ketoacidosis, okay? And so with this is going to occur in insulin-dependent clients, okay? So I'm trying to see if they have a DKA where it was. I will keep it going. And so this is more commonly seen in type 1 diabetics, and this results from an insufficient amount of insulin in the blood. Okay, and so what happens is that since we don't have insulin to pull the blood sugar out and into storage, that ends up causing us to have high blood glucose levels. And then mobilization and use of lipids to meet the cellular needs results in the production of those ketones or those keto acids. Okay, so when we're not breaking down our sugars to make, glucose broken down to pyruvate, etc., then we're going to start breaking down our fats and proteins. And it's good to do that normally, but it can, in excess, cause keto acids to go up. And so this may be initiated from an infection or stress, or it can result from, again, that error in dosage, infection, a change in your diet, alcohol intake, or exercise. So here is a fun little summary table about the development. Well, if nothing about it is fun, but the development of diabetic ketoacidosis, so that you can look into that and study it. Okay, and so let me pause here for a sec. Yeah, this is in figure 16.4, and so this would be diabetic ketoacidosis is going to be talked about on 408. And so this is figure 16.4 on page 409. And so what you see up here is the decreased insulin secretion or increase in insulin-resistant cells. And so then this leads to a decrease in glucose transport into the cell. And that can cause you to have polyphagia, which is hunger. It can cause you to have hyperglycemia, which is the high blood glucose, which then can go lead to glucosuria, which is an excess of glucose spills over into the urine. So then you can, test it on a dipstick. And then that can cause polyuria, which would be the increased frequency of urination, therefore leading to dehydration. Dehydration can lead to acidosis. Okay, also if you're dehydrated, you can be thirsty, right, and drink more water. The decreased glucose can also lead to hyperglycemia, which again can lead to glucosuria, which is the excess glucose, then polyuria, etc. So we can also have glycogenolysis, and so if you break those down into your words, glycogen is our sugar stores, and lysis means to break. So glycogenolysis means you're breaking apart our sugar stores, therefore releasing more sugar into the blood. And so then that would therefore lead to high blood sugar, etc., and go down there, okay? Or gluconeogenesis, sugar new create. This is when we create new sugars, etc. Or you can finally have lipolysis, or the breakdown of fats. And this can cause ketone bodies to form. And so basically this is an acidic waste that's formed in large amounts, and then that can cause you to go to ketoacidosis, and therefore again acidosis, or it can cause you to have ketonuria. And so again, this is on page 409 in your book, and it is figure 16.4. So what are the signs and symptoms? Well, this is nicely bullet pointed out on page 408 of your book. The signs and symptoms can be thirst, a dry, rough oral mucosa, warm, dry skin, rapid pulse, but it's weak and thready. It's not really strong and beady. It's just kind of like quivery a little bit. Your blood pressure is low as the vascular volume decreases. Then you can also have oliguria, and this would be the decreased amount of urine output. And this indicates that the compensation mechanisms are in place to help conserve the fluid in the body. Okay. So what are the effects of the insulin deficit? And so this is summarized in table 16.3. And so here you can see some early signs are going to be hyperglycemia, and the rationale would be, well, you have a lack of insulin. Progressive signs here could be like increasing hyperglycemia, and this could be gluconeogenesis owing to response by epinephrine, cortisol, and glucagon. Okay, you have dehydration that can occur, and this can cause polyuria, right? Or be caused by polyuria. And then you can have ketoacidosis, and this can be caused by the catabolism or breakdown of your different fats and proteins. And late signs down here could be coma due to the central nervous system, depression owing to acidosis and dehydration. So again, this is a really nice summary figure, and this is table 16.3 on page 410. So ketoacidosis is basically you develop it and then you demonstrate it by having rapid, deep respirations. These are called casemal respirations. And you can also have an acetone breath. And so basically this is when the breath of a patient actually is going to smell sweet and fruity. And you can also have just overall tiredness, and this is lethargy, right? So you're lethargic, and this is going to cause decreased responsiveness. And this can potentially demonstrate that you have a depression or a reduction in the central nervous system function because of the acidosis and decreased blood flow. Back in the day, doctors, before they had diagnostic tests, the way that they would diagnose diabetes is they'd have you urinate into a cup, and then the doctors would actually taste the urine because it would taste sweet if they had diabetes, right? Because there's extra sugar being excreted. So they'd smell it on their breath, and then they'd actually taste the urine, and that would be how back in the day they used to diagnose things. You also have metabolic acidosis, and this would be where you have decreased serum bicarbonate levels and decreased serum pH. And you can refer back to chapter 2 to read more about these things. You also have a dehydration that's going to progress, and this is going to cause renal compensation to be reduced, and therefore acidosis becomes decompensated and goes up. And this causes the serum pH to fall, because remember, our acid numbers are lower, our basic numbers or alkaline numbers are bigger. So as we have more acidosis occur, that means that our pH is going to fall. And if this happens, then you can lose the consciousness, right? It's not very good. This can also have other complications such as electrolyte imbalances, okay? And so the electrolyte balances are primarily going to cause you to have abdominal cramps, okay? It can also cause you to be nauseous and vomiting, and it can also cause you to be very weak and very tired and just lethargic, right? So this is why, like they say, if you're sick, you're puking, you have the flu, or you're just kind of feeling overall punky, drink a Gatorade or a Pedialyte, because that's basically electrolytes so that you can replenish them. People also say, like, drink some pink Himalayan sea salt and water, and that can help replenish your electrolytes as well. Okay. So how do we treat this? Well, we treat it with insulin administration, and then also the replacement of the fluid and electrolytes that you lost, okay? So a fun thing about those electrolytes and why they're important is that serum potassium levels may increase when insulin is administered because insulin promotes transport of potassium into cells. And so this is why sometimes we have to give you bicarb as well, because it's essential to reverse the acidosis, as well as it's a specific treatment to resolve the causative factor of the diabetic ketoacidotic episode. So just make sure that everything, again, is back to that homeostatic level. What about hyperosmolar, hypoglycemic, nonketotic coma? Whew, that was a mouthful, okay? So HHNK, sorry. This can occur in type 2 diabetes, and this is insidious in onset, and the diagnosis can be missed. So this often can occur in older clients, and it's assumed to be part of cognitive impairment, okay? And so this can result in severe dehydration and electrolyte imbalance, right? So this is talked about on page 409. There's like a little summary about it, so you can go and read about that too. So again, how does it manifest itself? Well, through hyperglycemia, severe hydration, which can lead to an increased level of hematocrit, a loss of turgor or the tension in your skin. It can cause increased heart rates and respiration, as well as electrolyte imbalances that can result in those neurologic deficits, muscle weaknesses, difficulties with speech, and abnormal reflexes. So what about chronic complications of diabetes? Well, these are discussed on page 410. So there are vascular problems that can occur, and this is where we have an increase in incidence of arteriosclerosis. You can have changes that can occur in both the small and the large arteries, which can therefore lead to the arteriosclerosis. You can also have microangiopathy, and this would be changes in that microcirculations. And so what happens is that you have an obstruction or a rupture of small capillaries in the arteries. And so because of this, if you don't have blood getting to something, remember from last week, that can cause you to have necrosis, okay, or the death of that tissue. And so if you have that no longer functioning, well then, or no longer there, then it can no longer function. It can also cause neuropathy or nerve pain, as well as a loss of sensations. It can cause retinopathy, and this can lead to blindness. And it can also cause chronic renal failure, and this is where you would have a degeneration in the glomeruli, or those like the little balls of the diffusion area, and those are in the kidneys. So again, here is a nice little summary of the vascular problems that can be associated with diabetes. And this is found in figure 16.4. And so you can have microangiography, okay, so that's with your, this is macro, so big blood vessels, right, or small ones. And so some of the side effects and problems can cause MIs or heart attacks, right, myocardial infarctions, or cerebrovascular incidents where you would have a stroke, peripheral vascular disease, arteriosclerosis, right? Or the microangiopathy can be from your kidneys, your eyes, your nervous system, right? And all of the different things that it can cause. So it's pretty serious. So we really need to make sure to pay attention to our sugar, and if we have diabetes, take care of it. So what about chronic complications? So chronic again means long-term, and these are on page 410. Well, from that previous thing, we can see that we can have that macroangiopathy, and this would be affecting those macro or those large arteries. And this can result in abnormal lipid levels because the high incidence of heart attacks, strokes, and peripheral vascular diseases can be caused by these increased lipids, right? So cholesterol, for instance, right? This may also result in ulcers on the feet and the legs, and these would be very slow healing. We also can have frequent infections and gangrenous ulcers, and if it's left untreated, amputation may be necessary. Now, my uncle, love him to bits and pieces, but he did not take care of his diabetes, still doesn't, and he has lost a couple toes due to gangrene, and yet every night he still has Manhattan and ice cream. So take care of yourself. You also have that peripheral neuropathy that can occur, and this is a common complication that's caused by the ischemia in the microcirculation to the peripheral nerves. And so because of this, it will cause impaired sensation, numbness, tingling, weakness, and potential muscle wasting. So here is a fun little picture of diabetic retinopathy, right? So again, this is in your eyeball. And so this is figure 16.5. So up here over here in A, you have the diabetic retinopathy in the eye. And so this would be where you have the blood flow normally goes through here. You have a microaneurysm, right? And then that can cause, a problem. But then if it ruptures, then it can lead to hemorrhage and an exudate, or like things are going to like ooze, right? They're going to escape. And then that can cause, down here, you can see that there's no longer really fleshy tissue, so the retinal cells can die. This one here is the neovascularization with the rupture in fibrosis. So, right, so sometimes you can create new vascularization, which is the neovascularization, right? And then here is what's going on with it in the eye. So you can see that there's a combination of the both. Over here in B, this is a retina from a case of advanced diabetic microangiopathy, which is going to show several aneurysms, which are these big dots or blobs. Okay, so again, that's figure 16.5. Looking histologically, then this is going to be what diabetes mellitus is going to look like with nodular glomerulosclerosis. Okay, so glomerular again is going to be in that kidney, and sclerosis is going to be this the degradation of the tissue, right? So this is what it would look like. It looks like this is an H&E stain or hematoxylin and eosin stain. So you can see just the cell tissue versus the cell nuclei, etc. Right? And so we have some fun pictures coming up, guys. This is great. All right, so that neuropathy, remember, is the peripheral neuropathy is a common problem, and it can lead to, like, neuro is nerve, and then opathy is something went wrong with it. And so if you have neuropathy, it can lead to impaired sensation, numbness, tingling, weakness, muscle weakness, right? All like the kind of like, you know how you get really cold and like like when you're sleeping and your hand falls asleep and it's that tingly kind of pain. It's kind of exactly what this is going to feel like. And so this is what an ulcer foot can actually look like. Okay, so this is the classic neuropathic diabetic foot ulcer. So note that the ulceration in the callus as well is circumscribed. And so basically what they're saying is it caused this ulcer, and even though there's a callus in here, the ulcer spread or ulcerated. Okay. So this is what happens when you have poor circulation. You can get an ulcer, it's untreated, it can cause a hole, right, and give you lots and lots of problems. So what about some infections? Well, these are common and they're more severe in diabetics. And so infections in the feet and legs can be caused by the vascular and neurologic impairment. And so some of the fungal infections that are common include those that are caused by Candida, and also this can be caused or be located either in the vagina or in the oral cavity of the person. This can also lead to UTIs, dental caries, or gingivitis and periodontal. And so the next slide is going to show you what happens with the chompers, right, your teeth. And so this is the periodontal disease in diabetic. So you have to note that there is a lot of inflammation. This red puffiness is inflammation. And there's also infection, which is going to be these black and brown areas. Okay. So this can happen if you don't take care of your diabetes, or you can have a Candidiasis infection. And so this looks like that's a pair of underoos from the 80s. Okay. So, but basically this is Candidiasis in the right axilla with satellite pustules. Okay. So basically, all these little things are pus-filled sacs. Okay. So this is what we need to make sure to pay attention to, make sure that we try not to do it. So what about other complications? Well, some of them are going to be cataracts, and this is on page 413. So cataracts are when you have an opacity in the lens of the eyes. So the eye becomes opaque. So instead of looking through and seeing like clear, it gets cloudy. And this is related to abnormal metabolism of glucose in the body. Also, if you're pregnant and you get gestational diabetes, then this can result in complications in both the mother and the fetus that can occur. And this increased incidence of spontaneous abortions can occur. So basically, if your sugar gets way too out of whack, then you can accidentally spontaneously abort the fetus. And so that's why they really do sugar tests when someone is pregnant, right? The infants can also be born to diabetic mothers, and if they are, sometimes they can be increased in size and weight for the date because they're kind of getting more sugar from the mom than what would be normal. And they may also experience hypoglycemia in the first hours postnatally because, again, remember, they're getting all their blood supplies from mom. And if mom has high blood glucose and then you're cut off because, you're born and they snip your umbilical cord, well, then you're not going to have sugar. So then you might tank and be like, oh my God, I don't have enough sugar. That's hypoglycemia, right? So everything just really works together. So this here is figure 16.9, and this is detailing the potential complications of diabetes. And so diabetes mellitus is going to be the decreased insulin that's available. That's going to cause increased blood glucose levels, and then this can cause altered lipids and protein metabolisms. Acute complications can include hypoglycemic shock, so low sugar, or diabetic ketoacidosis. What can happen in your brain is that we can have a cerebrovascular incident, such as arterial sclerosis. In your eyes, you can have cataracts that form or retinal microaneurysms. Both of those are not good. In your heart, you can have an MI or myocardial infarction, or it can cause arrhythmias, right? The wrong beating of the heart. You can have in your kidneys nephropathy as well as infections. Okay, so kidney infections, not fun. So you can have neuropathy, or that's going to cause, it potentially could cause impotence and infertility or urinary incontinence. You can also have the numbness and weakness that's typical with the neuropathy that are found in your extremities. Then this can also lead to peripheral vascular disease, such as ulcers, delayed healing, and gangrene. So moving on to thyroid disorders, okay? So these are going to start to be covered in page 413, okay? So you have two different thyroid hormones, and these are released in response to TSH, or thyroid stimulating hormones. This disorders may result from a pituitary or a thyroid gland dysfunction, and one example of when you have a thyroid disorder that can be presented, it could be the presentation of a goiter. When my mom had thyroid cancer, she actually had a goiter, and it was really interesting because we never noticed it because we saw her enough or a lot. But then when the doctor, and it was like winter, so turtlenecks, yeah. But that's one of the common presentations of thyroid issues. You can also have hyperthyroidism, which is also known as Graves' disease, or hypothyroidism, where your thyroid is not functioning correctly. So looking at this, okay, this is the hypothalamo-pituitary tract, right? So the hypothalamus-pituitary-thyroid gland feedback. And this is figure 16.3 in your book. So up here, the stimulus is going to be either cold or stress, and it's going to signal the hypothalamus, right? And then in step 2, we have the hypothalamus that's going to have increased secretion of the TRH into the blood. Then you have your pituitary glands, and these are going to the secretions are going to increase the amount of TSH that is going to go into circulation, as you can see here. And then in 4, here we have the thyroid gland, and this is going to increase secretion of T3 and T4 into the blood. And so you can see then that these little red dots are going to have increased circulation, right, into the blood. Then down here in 5, the target cells are going to increase the metabolism. And then in 6, we have that negative feedback come back. And this is where there's going to be high levels of T3 and T4 that are going to inhibit the secretion of TSH and TRH, okay? So this would be the hypothalamus-pituitary-thyroid gland feedback mechanism with thyroid hormone. That is a mouthful. And again, that is figure 16.3. So again, what is a goiter? Well, we get to see a picture of it on the next slide. But this is, you can have an endemic goiter. This is where the hypothyroid condition, so low functioning thyroid, and that occurs in regions with low iodine levels. And this can be, those low iodine levels are potentially from the soil and food, right? In the States, we actually have iodized salt so that we can actually make sure that we get the iodine levels that we are looking for. We also can have goiterogens, and these would be foods that contain elements to block the synthesis of the T3 and the T4 hormones. You can also have a toxic goiter, and this results from the hyperactivity or overactivity of the thyroid gland. And so this is figure 16.14, and this is where we have an endemic goiter and hypothyroidism. And so this is showing you the structure of T4 next to the structure of T3. So basically, T3 is because you have 3 iodines, T4 is because you have 4 iodine atoms. The goiter is the enlargement of the neck here in front, okay? And then how the goiter is going to develop is that you can have low blood levels of T3 and T4 that stimulate the hypothalamus, and then the hypothalamus increases the TRH secretion. Then the pituitary is going to increase the TSH secretion. Then TSH stimulates the thyroid hormone. And then step 5 is that the increased TSH levels are going to lead to an enlarged gland, which can cause that goiter. Okay. You can also have an iodine deficiency, and this can cause decrease in synthesis of T3 and T4. And this can lead to hypothyroidism and go back up, and therefore, since it's not functioning, you're going to have those lower levels of T3 and T4. Well, what about the opposite? Well, with hyperthyroidism, this is related to an autoimmune factor. So hypermetabolism and increased stimulation of the sympathetic nervous system. This is going to potentially cause increased body temperatures, sweating, soft, silky hair and skin, reduced BMI, insomnia, and hyperactivity. You can have a toxic goiter, and this can also be exothalamus. Okay, and this is where you have the protrusion of your eyes. Okay, they're staring eyes, decreased blink reactions, and eye movement. And so there's going to be a figure next with picture that's on figure 16.15. And then this can result in an increased tissue mass in the orbit of the eye, and it may result in visual impairment. And so this is an example of hyperthyroidism that is demonstrating itself with exothalamus. Okay, and so as you can see, the increased tissue amount is going to push that eyeball out. Okay. So the hypothyroidism is due to iodine deficiency, and this can also be called Hashimoto's or Hashimoto thyroiditis. And this is an autoimmune disorder that can arise from a low functioning thyroid. So this hypothyroidism can also result from a tumor, and what you would do is you'd have to surgically remove or treat that gland. You can also have creatinism, and this is where you have the result in short stature and severe cognitive defects that occur because you're not getting the right hormones at the right time. And this is basically, can be treated from untreated congenital hypothyroidism or low thyroid. And this may be related to iodine deficiency during pregnancy. So hypothyroidism manifestations. How do we know what's going on? Well, the goiter can be there, and the goiter, if the cause is endemic, can be from iodine deficiency. You can also show an intolerance to cold, an increased level of BMI, so you're a little larger, right? You're tired and you're just not feeling very good. You're just kind of blah, so you're lethargic and fatigued. You have a decreased appetite, and then myagnoxia can be severe and in untreated hypothyroidism. And so this would be like non-pitting edema in the face, and you can have a thickened tongue, or you can have a myagnoxemia coma, and this would be where you have acute hypotension, hypoglycemia, and hypothermia. So low blood pressure, low sugar, low temperature that can result in the loss of consciousness. And again, this can be very life-threatening if it's left untreated. So you can compare hypothyroidism and hyperthyroidism, and this is in table 16.5. So this would be a good little summary to look over. Right? What about your adrenal glands? Okay, so your adrenal glands, this section starts on page 420, and these include your adrenal medulla and your adrenal cortex. And so your adrenal medulla is the phenochromoscytoma, and which can be the complication or disease that results from a problem with your adrenal medulla, or Cushing's disease or Addison's disease that can be caused by your deficiency in your adrenal cortex. So your adrenal medulla, this is phenochromoscytoma, and this would be where you have the benign tumor that's occurring in the adrenal medulla, and this is going to secrete epinephrine, norepinephrine, and possibly other substances. And occasionally, this can be resulting in multiple tumors. This can cause you to have a lot of headaches, heart palpitations, sweating, and intermittent or constant anxiety. That sounds like my life. Just kidding. All right. With the defect in the adrenal cortex, and specifically talking about Cushing's syndrome, this is on page 421. This is caused by an excessive level of glucocorticoids, and this is possibly due to the result of adrenal adenomas, pituitary adenomas, ectopic sarcoma, heterogenic conditions, or substance abuse that can all cause the lower levels of those glucocorticoids. Okay. Some changes that are going to be resulting from the Cushing syndrome would be a change in the person's appearance. And so you can have more of a round face with a ruddy color, like just kind of a reddish, pinkish ruddy. You can have truncal obesity in the truncal area of your body with a fat pad that is between the scapulae. You can have thin limbs and thin hair, and you can have a fragile skin and striae or stripes in your skin. So there's a picture coming up that's going to showcase all of these, right? And then you can also retain sodium in water. It can suppress the immune system response. It can stimulate the erythrocyte production. It can have emotional liability and euphoria that can be a side effect. It can cause increased catabolism or breakdown of the bone and protein that's occurring. It can have delayed healing, and it can also cause an increase in insulin resistant and possible glucose intolerance. So here is a picture of what Cushing's syndrome can look like, and this is figure 16.16. And so in figure A over here, this is the girl before the onset of the disease, and this is the same girl 4 months after the diagnosis. And so we can see the characteristic facial changes with the puffiness and moon face. So with the Cushing syndrome, again, this is going to be a kind of more of a picture diagram. And so this is figure 16.18. And so these are the typical appearances that you're looking for. The thinning hair, the mood swings, insomnia, the loss of libido, the subclavicle fat pad that's going to occur kind of, in your shoulder area, the buffalo hump in the back of the back. You can have thinning extremities, and muscle wasting because of the fat metabolism. You can have truncal obesity, which is the belly sitting here, with the pendulous breasts, they're more saggy, and abdomen, right? So both of them are bigger and more saggy. And then you can have the broad purple striae, and this would be like the tiger stripes of purple on your skin. You can also have a cause of thinning pubic and axillary hair in women, and ecchymoses, which are these like kind of agey spot things. And then if you do have a wound, it can cause impaired wound healing and a delayed immune response. And then you can also have thin, fragile skin. Okay. What about Addison's disease? Well, this is due to a deficiency in adrenal corticoid secretions. And this is an autoimmune reaction that is basically, it's a common cause. It's from autoimmune reactions. And the adrenal gland may be destroyed by a hemorrhage or from an infection. And so basically what's going to happen is that we can have decreased blood glucose levels, inadequate stress responses, fatigue, weight loss, frequent interactions, low serum sodium salt concentrations, decreased blood volume, hypotension, and high potassium levels. Okay. And so here is a little summary table, and this is figure 16.6 on page 423, and this would be the comparison of Addison's disease with Cushing's syndrome. And so Addison's, which is going to be the adrenal insufficiency, is going to be the deficit of corticosteroids, which are the glucocorticoids and mineral corticoids. It carries a high risk of infection. There's a poor stress response. It can cause weight loss and fatigue, as well as anorexia, nausea, and diarrhea. It can cause hypo or low blood pressure, hypotension, syncope, or hyperpigmentation. Where on the other hand, Cushing's disease is from an excess glucocorticoid, which would be cortisol. And this carries a high risk of infection. You have a poor stress response, and it can present itself with a moon face, buffalo hump, obese trunk, muscle wasting in limbs, osteoporosis, etc. You will have striae, the bruising of the skin, high risk of infection with Cushing's, and then also hypertension, so high blood pressure, and then glucose intolerance. It can also cause fatigue, weakness, and delayed healing. So that is the end of that chapter, and we will see you guys in class. Bye.